Hi, welcome to an introduction to SBIRT. I'm Laura Saunders. I've been using and guiding others in the use of SBIRT practices for the better part of 3 decades. I started as a researcher where I did the screening and brief intervention as a part of smaller pilot studies. As our research support at a national level grew and it was apparent that SBIRT worked, I oversaw the work of a team of people who delivered SBIRT services. Now I spend most of my time teaching and guiding others in the use of SBIRT and in the use of motivational interviewing. Today, I'm glad to be here with you at the start of your SBIRT journey. Screening, brief intervention, referral to treatment. That's what SBIRT stands for. Today, what I hope to do is to provide you with the rationale for annual universal SBIRT. I want you to understand what your role as an FQHC provider is in the SBIRT process and provide you with some information to allow you to think of some reasons why you might want to implement SBIRT in your setting. Knowing the why, when, and how of your role in the SBIRT process. In this short video presentation, we'll be covering a bit about the importance of an annual universally administered substance use disorder and/or mental health screening for you and your patients. Knowing why, when, and what your role is in the SBIRT process makes it most likely that you'll do your part. When each member of the care team does their part, everyone does a little and no one has to do a lot. There are lots of reasons why you might consider doing more to support SBIRT. After this short video, perhaps you'll know more about what your personal why for doing SBIRT is. The SBIRT process is a series of steps, screening people to ascertain who needs additional questions or who needs a pat on the back. Those additional questions help us titrate what kind of conversation or referral to treatment does a patient need to best meet their needs, dependent on where their symptomatology is landing them. What SBIRT is it's a one-on-one clinical prevention service. And when it's delivered universally, it's a population or public health intervention. The goal of SBIRT is not to make decisions for people, not tell people what they have to do about their use of substances, but rather what our aim is to encourage and support movement from the right side of the continuum as far as we can to the left, celebrating each step towards the left as a part of harm reduction. SBIRT is good for everyone. Obviously, we want what's good for our patients. We don't want them going through life with conditions that have a major effect on their well-being, and then we don't even know it. They don't know it. It's a setup for misdiagnosis and mismanagement of their symptoms. When an entire population does better, it's better for everyone. SBIRT clearly reduces costs. You'll likely be quite impressed by the economic impact of the overuse of alcohol and drugs. SBIRT helps address that head on. When people are getting the best care possible, it's good for us as a healthcare team. It's rewarding to you when people get better. That's why you're in the field of caring for humans. You care about people and you want to see them live healthfully. When each member of the care team does a little, no one has to do a lot. And ultimately, collecting data on substance use disorders is a UDS reporting requirement for FQHCs. In these times of extraordinary burdens on healthcare teams, efficiency, accuracy, and cost savings are ultra important. First, let's talk about how viewing alcohol and drug misuse as a continuum helps us help our patients. When we look at people's use of alcohol or drugs dichotomously, we look at people as though they either have or don't have a problem with alcohol overuse or drug use. When we do that, we're not taking advantage of a tremendous opportunity to help people not get to the point where their use is obvious, where we are, oh yes, you have a problem with alcohol or drugs. In order to think about problematic or non-problematic use of alcohol, we have to first just step aside for a moment and think about what is a drink. A drink is, in general, it's a 12-ounce beer, 4 to 5 ounces of wine, and a shot, one shot of alcohol, which contains 1.5 fluid ounces. The low-risk drinking guidelines, the way that we arrived at those is through research that was done by the National Institute on Alcohol Abuse and Alcoholism, NIAAA. And what they did is they reviewed, the NIAAA scientists reviewed about 200 studies. And they were looking at when people drink this much, this often, when do the negative consequences start? The negative consequences that they were looking for come in a myriad of domains: psychological, family relationships, legal, religion, spirituality, biomedical. Nothing on this list is likely to surprise you. We know that alcohol and drug overuse has severe biomedical consequences, that unhealthy drinking and drug use impact many of the things that we're commonly treating our patients for. Think of how having better information on how your patients are using alcohol and drugs would help inform diagnosis and treatment. So when they looked at when did these kinds of problems arrive as compared to the amount that people were drinking, what they found was that when men stay below 4 standard drinks, no more than 14 in a week, and women, no more than 3 standard drinks in an occasion, no more than 7 in a week, they didn't have those kinds of negative consequences that we previously listed. Those biomedical consequences were less. So why should we do SBIRT as a universal procedure? Why not just pick out people who we might want to ask about their use of alcohol and drugs? Well, the rationale for universal SBIRT is that at-risk, problem use, and dependence are common. It's common in the general population. It's common amongst population subgroups. There is nothing about demographics that can help us say, oh, let's only screen these people or these people. It's common amongst a lot of people. So we also know that the adverse impacts of substance use are huge: health, social, money, economic. And we know that SBIRT reduces risky and problem substance use and its adverse impacts, like those adverse impacts we were just talking about. We know that at-risk or problem use or dependence is something that affects 30% of American adults. Therefore, universal screening makes a lot of sense. In your state, we know that Illinois has a slightly higher rate of substance use disorders in the past year, and the need for substance use treatment for alcohol, drugs, and both is rising. So the bottom line is that at-risk drinking and drug use occur in all population subgroups, and all patients should be screened. What is the definition of screening? Screening is a big part of SBIRT. Well, what screening is it's a rapid, proactive, systematic procedure applied to an entire population or client populations to identify individuals who may have a condition or may be at risk for a condition before obvious manifestations occur. What conditions warrant screening? Conditions that are an important health problem. There should be a latent or early symptomatic stage so that the screening pays off. There should be a test that is easy to perform, interpret, acceptable, accurate, reliable, sensitive, and specific. There should be an accepted treatment for the condition. Effective. The treatment should be more effective if it started early, and diagnosis and treatment should be costly. It turns out that we have accurate, acceptable, reliable, sensitive, and specific tools to help us screen for alcohol and to help us screen for drug overuse. The Audit C is the tool that is used to ascertain whether people are drinking beyond those recommended limits and whether or not they are binge drinking. We ask them these 3 questions. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you're drinking? And how often do you have 6 or more drinks on one occasion? There are points associated with each one of their responses. The points are added. Men who have more than 4 points, women who have more than 3 are then invited to answer additional questions about their use of alcohol. For drugs, we can ask a single question. How many times in the past year have you used marijuana, an illegal drug, or used a prescription medication for a non-medical reason? Anything more than none indicates that we want to ask the person more questions. The questions that we ask to do the brief assessment are the audit, the Alcohol Use Disorders Identification Test, and the DAST, the Drug Abuse Screening Test. Depending on how people answer the 10 items on the audit or the 10 items on the DAST, we make our recommendation as to what should happen next. Many people will benefit from a brief intervention. Some people, if they fall into the likely dependence category, will need a referral to treatment. For none of this is the goal, the acceptance of a diagnosis or a label. We use motivational interviewing to help people best consider making a behavior change. Again, the goal is the reduction or perhaps the cessation of substance use, or to facilitate them accessing another resource. Maybe they need an assessment by a specialist or specialty-based treatment, or maybe they would benefit from a mutual help group. So depending on the results of the screen and the brief benefit assessment, it guides us to knowing what this person is most likely to benefit. So we use the results of the screen and the brief assessment to guide us towards what's most likely to be the best course of treatment for this person. Abstinent persons or people who are using in a low-risk, non-problematic way just need reassurance and reinforcement. If persons are indicating that their use puts them at risk or has created problems for them, they're likely to benefit from a brief intervention, a motivationally based brief intervention. And persons who appear to be likely dependent will do well to accept a referral to treatment. Sometimes persons are not quite ready to take that referral to treatment, and we can support them in the primary care setting with the brief intervention. How well do these brief interventions work? Well, this data is quite old. One of the first, probably one of the most famous brief intervention trials. This was a provider-based intervention. It was called Project Treat. And what they found was that the provider-based interventions had lasting effects across a whole bunch of really significant areas. So why exactly do we do these brief interventions? How well do they really work? Well, when persons who were at risk or problem users got a provider-based brief intervention in the year after the intervention, injuries went down, emergency department visits went down, hospitalizations went down by 37%, arrests decreased, and crashes decreased by 50%. When we start to assign numbers to those, when we start to assign dollar amounts, life and quality of life amounts to that, it's quite significant. So who will benefit? Who will benefit from SBIRT? Who will benefit from SBIRT are the people who are at risk, problem use, or dependent. Dependent persons, again, those are the people we tend to know about. So it's that at risk and problem use where we really see the benefits of SBIRT. Those are the people that we might not know about. So let's talk about the cost savings. for 1,000 primary care patients. If we are screening for unhealthy alcohol and drug use, we save $300 per patient per year, $1,300 if we add in a depression screening, $571 per patient when we add in cigarette smoking. When we take that and we multiply that out by the 1,000 patients, we multiply that out for all 1,000 patients, and then we look at our 1 year savings per patient screened, it comes out to nearly $600 just screening, brief intervention, referral to treatment, located in the primary care population, located in the primary care setting. It's not surprising that there are lots of authorities that recommend alcohol screening and intervention. You can see all of their logos here. So what's up next? Who's up next? What will happen is that you and your colleagues will decide how this might work in your setting. There's lots of information out there on what works. You can also access a coach like me or someone else who knows a lot about implementation in SBIRT and how to help guide your unique practice setting through the process. And so what it comes down to is you thinking about what would you be willing to do. So today we've talked about how there's a large prevalence and impacts of risky use, problem use, and dependence. Brief substance use disorder interventions are clearly effective. They reduce costs, they save lives. The SBIRT process meets the UDS requirement for FQHCs. To support patients at your site, you might offer pharmacotherapy and behavioral support in the general healthcare setting. I invite you to learn more about how SBIRT is being delivered at your site and provide advocacy and support for the work. Thank you for your time.